And hi, everyone. TJ Allen's I-45 Now. Welcome to a new edition of Healthcare Unmasked, presented by UTMB Health on Pod Now, I-45 Now. And we're glad to have you along. And also welcome in our guest for the show today, Dr. Juarez from School of Nursing, specializing in research regarding HIV. Now, you would think when we talk about HIV, this is something that a lot of people have the perception has been tackled. Actually, it hasn't. It is still a problem. Dr. Juarez, thanks for coming on with us here today. We appreciate it. And it was fascinating. You and I had our preview interview that I do with all of our guests on here. And when I hear what you're telling me about HIV, particularly in the metro areas and in Texas, it is something that is indeed still a problem. Tell us why that is.
Yeah, sure. So just want to say thanks for having me.
Sure.
I like to get the message out. But yeah, so I think what we're doing overall, HIV in Texas, it's getting better. However, it's the ones that kind of fall off our radar. That's what's causing a lot of continual disparities, right? So I think definitely, we're seeing a lot of increases in a lot of historically marginalized communities, and economically marginalized communities are bearing the brunt. Those are the ones that we need to do a little bit better in trying to reach them. So whether you're up in Dallas, out in Austin, San Antonio, down in the Rio Grande Valley, or even out west in El Paso, just across the board, we are still seeing some areas that we do need to work on. I think in one of the links that we had that we looked at, we see the overall numbers going down, which is great. But however, they're still within, when you start breaking apart the numbers, that's where we start seeing a little bit of the problems that are continuing.
And one of the things we talked yesterday, and I wanted to revisit this, is that there's a lot of factors that go into that. But let's talk about just the numbers. Yes, overall, the rates of HIV infections have gone down.
Right.
But that's number of new infections.
Right.
But the number of folks living with HIV has continued to increase.
Absolutely.
Because of advances in medical treatments, advances in care, that now we have more and more people, including in this county, a high number of folks who are living with HIV.
Absolutely.
How has that perspective changed on your research and looking into this now? Because beforehand, early 80s into the 90s, early 2000s, that he was looking at, okay, we got to stop HIV infections. And that was the focus versus, all right, now we got to find a way to those who are infected to treat them, which has become, I don't want to say the norm, but it is in many cases. Right. If you watch online or on TV or see any billboards, you would think HIV treatment is just like getting a bottle of aspirin sometimes. In many ways. But talk about the difference now in the medical community when approaching those who are living with HIV.
Right. So I should say too is that's absolutely right. So there's definitely, I think nowadays, I think the thing with HIV science, right, there's the you're seeing these improvements, right? While HIV is still one of the highly stigmatized issue or condition, right, or diagnoses, the thing is though is that because the HIV science has really advanced, HIV has now, I think the overall kind of perspective of HIV now is that it's basically a chronic disease that is easily managed. So I think this is why you're seeing that reflective in the numbers, right? You're seeing these high increases of people living with AIDS or living with HIV/AIDS, and that's a good thing, right? Because they're actually getting the treatment they needed. Now I think I hate to be a little bit cliche, and it's not, because this is the way us HIV researchers talk, but we always kind of talk about this continuum, right? The HIV continuum. So one of them is prevention, but I think where the individuals or the persons living with HIV/AIDS or living with HIV, they're able to access a lot of these advances in HIV care. And the thing that we're starting to see there's problematic areas in it, but I guess just to stick on the positive, we're seeing these individuals that have their HIV issues, taken care of, and now they're, because they are living longer, they're now starting to experience the other disparities that most Americans tend to experience, like diabetes, cardiac disease, et cetera, et cetera. But really, I think the biggest change has been, that perspective that HIV now is just really a chronic condition that's easily managed.
And when we come back, we're going to explore on that part of the topic a little bit more. Dr. Adrian Juarez, he's with the UTMB Health School of Nursing, and is leading the research on HIV. He has by the way, if you ever look at his resume, what he actually does is much longer than that one topic, by the way, border health and everything else. But we're going to talk more about that when we come back after these words from our sponsor, UTMB Health.
There's nothing more important than quality health care for you and your family. That's why UTMB Health is in the communities where you live, providing easy access to innovative care. At UTMB, we know our patients need personalized care to lead healthy and fulfilling lives, providing everything from primary care and specialty care to urgent care and emergency medicine. UTMB knows healthcare. UTMB knows you. To find a UTMB doctor near you, visit utmbhealth.com.
Hi, welcome back to UTMB Health's Healthcare Unmasked. I'm TJ Alts, and joining us for those of you who missed the intro, Dr. Adrian Juarez. He's with the UTMB Health School of Nursing, and where he's, I'm going to say, the head honcho elite researcher on HIV infections, and that as well as border health. I should point out too, where a lot of your specialty, because you spend a lot of time out in your hometown of El Paso too.
I sure do.
And we'll have to have you bring you back just talk about that as well.
Yeah.
But we are talking now on HIV, and I think a lot of folks would hear, well, why are we talking about this topic? It is still a problem, and unlike what we were dealing with before, where we're talking about new infections on a regular basis, now what we're talking about is folks living with HIV. And you had said right before we went to the break that now it's being treated like a chronic condition. Right. What are some of those factors that are going into play where it's, and so people understand it may not be medical on this, is acute, like if you get a cold, you're going to get over it here in a couple of weeks. If it's chronic, that means it's with you all the time, like cancer or something like that. Right. But but the difference in what do you think is what led to folks of looking at it as, oh, this is something that's treatable and livable now.
Yeah.
And although if it moves from HIV to AIDS,
right,
the likelihood of you surviving is a lot less.
Right.
But let's go ahead and talk about just HIV, which is the first phase here of why you think it is that so many folks treat it like a chronic disease versus a preventable disease, I should say.
Yeah. No, I'd be happy to do that. So the thing is, it's like just the access. I think HIV advocates, right, whether it be community-based organizations or just people in general that really advocate for access to a lot of these care opportunities. I think that really shows. I think that's probably some of the big credit, but also on the research side, you have a whole heck of a lot of researchers and just providers themselves that are really pushing and really understand the ins and outs of HIV care. So I think most a lot of that credit goes to those two providers and advocates. Now the thing is though is that in a way I don't want to use the term these numbers that we're seeing with either with the infections, we're kind of like let our guard down. And I think that where this is relevant to the chronic condition or the chronic approach to HIV care, I think that's where you start seeing also that kind of like, well, it's easily manageable. I feel great, right? I think that's one thing that at least in my nursing practice, that's one of the biggest things just in general that we see with a lot of people that are seeking whatever type of care is that they're like, well, I feel great. I don't need to do this anymore. But there are other issues as well too. So for example, some of the we have this what we call medication fatigue, right? Even though it can just be one pill a day, that one pill a day, may bring out a lot, there may be a lot of resistance and a lot of just extra issues that we sometimes overlook. And that can also, really kind of change the course of HIV management, right? So if someone stops taking their medications, their antiretrovirals, right? The thing is that they can become resistant, or they can, their numbers, their viral loads and other measures of HIV status, right? May change up a little bit. And this is where we start seeing kind of like, oh, they fell off, we call it, I guess the term is, loss to follow-up or medication adherence failure, those kinds of, I hate to use that kind of language, but because it has a negative connotation. But I think this is where, something that's fairly easily managed, right? This is where they can, fall off, the care trajectory. But I do want to also emphasize too that, even though that HIV is a chronic disease and it's easily manageable, it's still, we can't forget that though those individuals that are living with HIV still, have a lot of challenges that they do. Even though that, and I always kind of say this too, because, being HIV positive, has its, connotations, right?
Mm-hmm.
It can mean a lot of different things for a lot of different people. But I also want to emphasize too that, HIV, while we can see it from a provider researcher standpoint, it's fairly easily managed, right? But however, this is more targeted to the individuals that are living with HIV. By in no means are we being flippant or dismissive of the challenges and that they may experience on a daily basis. So I just wanted to put that out there. But either way, I think this is where some of that these numbers, with persons living with HIV, I think this is where we're, some of the issues and challenges that they have in that population group, I think this is where it's coming from.
And you have drugs on the market that you're highly publicized. Like we're showing folks now the website for Biktarvy that's out. And when you see these commercials over and over and over again, I think it at that point, society in itself thinks, oh, okay, well, let's just take a pill.
Right.
And sometimes that will lead to actions that put people at risk. So, and I just wanted to get your take on how much of that may be playing in a role in the public's perception and those at risk for HIV contraction, that basically, oh, well, if it does happen, I can just take a pill.
Right.
That's a lot of things you really don't want to get it in the first place.
Yeah, absolutely. And I think this is where we're starting to see a lot of issues with other STIs or sexually transmitted infections, right? I think people, because of the highly stigmatized label, right, that HIV has historically had, right? We kind of focus. I think people tend to focus on that aspect, but then the thing is, though, remember how HIV is transmitted, though. There's still risk for other types of infections. So, for example, this is why we're seeing, syphilis just all across the state, right? Definitely in the metro areas, definitely in places like Galveston, right? Where Galveston is doing a really good job, right? But the thing is, though, is that we're still seeing, these STIs that are still being transmitted. For example, now you have the syphilis, congenital syphilis. Then you have, I think we're going to have issues again with Mpox, those kinds of, those, I think those issues, because they're easily treatable, right? There's cures for a lot of these conditions, a lot of STIs, right? You could just go get your shot for gonorrhea,
right?
You can easily treat syphilis. I mean, there's challenges to that. I don't mean to oversimplify it, but nonetheless, I think individuals tend to focus on the HIV aspect because of the labeling, right? The stigma. But then at the same time, we sometimes people forget, like, oh, there's other conditions, there's other STIs that may come through that exchange of bodily fluids, right? However it happens.
Right. And that was something that I found interesting in my previous conversation with you on this subject, was that when what you also track is not necessarily new HIV cases, but you want to see the other sexually transmitted disease cases too,
Yeah.
because there's a correlation there. If those are increasing,
Yeah.
the likelihood is you're going to see HIV increase.
Right. Absolutely.
As well.
Yeah.
And you talk about the stigma. Let's just, go at that it is still it's within the gay community, the gay men community. Men actually born sex at birth is the
Right.
term that's used.
Yeah.
That is most prevalent as far as living with HIV.
Right.
But you are seeing in some other segments of the population some rise, and they're not in the LGBTQ community. They're actually in the heterosexual community. Talk about that.
Yeah, so I should just a little bit of a backdrop. Yeah, most of my experience has been working in these LGBTQ communities, right? But then when I came back to Texas, right, I started looking at where's the need, right? What are the community organizations? What are the HIV advocates and care providers that I spoke with? Where's the highest need? And I was really surprised, that a lot of them have said are heterosexual communities. There's a lot of heterosexual transmission of HIV now, and that's women who are born, who are assigned women at birth. I think a shorter term would be cisgender women, right? They're bearing the brunt of HIV infections, and we see this of new infections. We're seeing this in the marginalized communities, whether it be the communities of color. If you want me to get more specific, Latino, Latinx, Hispanic communities, or Black African American communities. Those are the ones, at least when it comes to heterosexual women, we're still seeing increases in those areas, right? And that is our state health services have identified that they are a population in need, and they are a population of focus. I want to say priority population is a terminology they use, but definitely, we see a lot of that. And just a little bit of just to throw out some numbers, these HIV infections, 80% of these infections in heterosexual cisgender women come from heterosexual contact. Now, the remaining 20% comes from, it's estimated, and there's pretty good evidence behind it, but that comes from IV drug use and other things, other types.
Yeah, and in fact, we have right now, for those of you looking on the screen right now, Dr. Juarez can see what I popped up, but this is from the state's health department of state health services, and on the left, where a lot of that orange is, that pie chart there, that is women. With new diagnoses of now this report was issued in 2023, but the numbers are up through 2021. And that big orange you see there, that's heterosexual women who are get new diagnoses with mode of transmission, this is through sex contact or swapping of body fluids. But then you do see that large blue wedge there, and that is intravenous drug use. And injectable, I think is the actual term that's used there. That's a large chart, but the biggest percentage is still through sexual contact.
Right.
On there. Then you go over to the male chart, and it is the blue that you see there. That's the majority, and that is gay men, cisgender men. Where that sexual contact is leading to that, and the percentage that of drug use that's leading to that is a much smaller percentage of the overall compared to the women there. But there is when you take that and combine it with gay sexual contact and intravenous drug use at the same time, now that number goes up considerably. So one of the areas that I wouldn't say it's the leading, but a good contributor is the drug use side of things, which goes to the bigger story across the board on a lot of health issues in our state, here locally as well, is intravenous drug use.
Absolutely.
That is still prevalent, and still one of those things that I know the School of Public Health is
Yeah.
really trying to address on educational purposes on that.
Yeah, and if I can say, and I think, this is why, the governor's focus on fentanyl and things like that, it all stems from that,
Right.
the opioid use and things like that. So we can't dismiss other issues like that. So for example, when you look at just HIV in itself, but then when you have someone with a diagnosed or undiagnosed substance use disorder, their risk really goes up, regardless if they're MSM or gay men, or if it's a commercial sex worker, things like that. It really doesn't matter. But when you throw the element of substance use, and when we talk about substance use, there are certain characteristics of substance use trends, right? So some communities, so for example, have lower IV drug use. Other communities, maybe, I know, like for my work, out in El Paso, we have heterosexual women who not necessarily are reporting IV drug use, but they are reporting high alcohol use, right? So we all know, no matter if you're, no matter the substance, there's at many times that inhibitions tend to be lowered
Right.
with that. So that caused, that's where we're starting to see the risk. And going back to just if I can just plug this in about the heterosexual females, right? Cisgender females. The thing is, though, it goes hand in hand, right? So we were talking about, HIV, right? But then there's other issues. So this is why, we can easily see a lot of these increases in congenital syphilis, right? That comes from, these individual, or these babies are being born because their mother transmitted, syphilis to these infants. But the thing is, though, is that, again, it goes back to, yes, HIV transmission. And then, then there's the other elements too, like the congenital syphilis. So this is how a lot of these issues, they kind of go hand in hand. I don't know if I was a little bit clear about that, but either way.
But they do. Wait, and this is the case in many, particularly what we call infectious disease.
Right.
That is the case. What we see an increase in any of these, almost always you can go to societal problems within that. And so when you see an increase of one infectious disease, that's the increased risk of everything else that would fall into that as well. Drug use coming in there, unprotected sex, not, and then, and as you said, the inhibitions, whether it's drug, alcohol use, that, that brings folks kind of feeling easier about it,
right?
Which is always going to be a problem.
Yeah.
And so that goes into the next question for me to you is, all right, hey, there's no doubt that this is a problem. And how are we going to address it? What's the simplest thing without getting a lot of government money involved or something like that, that we can tell the public now of, hey, here's how we can get a stamp on this so that we can tamp it down.
Yeah. And I think that question, right? The economic question, I think that's very important, especially for the Texas context, right? Here in Texas, resources are very, very limited, and we're a huge state, right? I mean, we got 30 million plus people here, and we only got X amount of money to be able to work with. So the thing is, though, is that, the economic factors then start playing a part, right? So the thing is, though, is that, okay, and actually this is where a little bit of the challenges in my work have come in, because so when we have these communities, right, sometimes I think, especially, right now I'm working on within, cisgender heterosexual communities, right, with my HIV prevention, HIV care work. But the thing is, though, is that one thing that we're seeing is that a lot of these numbers may be a little bit smaller, right? And one thing that I find challenging is trying to convince funders, right? Because the thing is, though, is that especially in a state with very limited resources, and I totally understand the logic behind it, right?
Right.
We gotta focus on what delivers the maximum impact. But then again, the thing is, though, is that how can we kind of navigate these numbers, while, let's just say, in a place like El Paso, where 20 women right, were tested positive for HIV in a 30-day period, right? El Paso's almost 1 million people, so 20, right? When you see it, it's kind of a hard message to sell. But the thing is, though, is that I always, I think where I've been successful, at least talking with, with individuals who are really concerned about the the resources and the allotment of resources. I always say, well, these individuals, if they fall out of care, when they come back to you, it's going to be X amount more.
Right. It's going to be this much more money.
Right. Exactly.
And sometimes that's how you have to sell it.
Yeah.
And I don't mean to sell it as in a crass way.
Right.
But it is the way to make the pitch. Yeah. It is not it's not the emergency at the moment, right, as we may have been at one point. Exactly. So it gets a lot of attention, a lot of funding pointed that direction.
Yeah.
But as we start, as I said, folks treating it like a crime, because the folks that may have or at risk of having HIV may be treating it as a chronic condition. So is the society that could fund research, fund care, and they're also looking at this as well. We've already got the drugs on the market. Why do you need us to fund this?
Right.
But it still goes down to is if you are able to get a message out about safe sex, cut down on intravenous drug use,
right,
and you're not only focusing on HIV, you're focusing on a whole array,
right,
of infectious diseases that are out there.
Absolutely. And the thing is, though, it's just so there's 2 points here. So that even when you have certain STIs, right, that just increases your HIV risk because there's open source, things like that. And, HIV can get in a lot easier. But I will say one surprising thing that I found, and this is where I'll plug in an upcoming manuscript, right, that's coming out, is some of my work in El Paso. One thing that surprised me, it was not unexpected, is that when I was looking at the IV drug use population, but I was very surprised that a lot of these individuals who are at risk really said that they don't inject anymore. And the reason being is because fentanyl, right, it becoming the drug of choice now, a very dangerous drug of choice. I'll add it to that. But the thing is, though, is that they're smoking it. They're not really injecting it anymore. Things like that. So I wonder, and this is what, this is what I'm looking at right now. How is that going to change the numbers? I mean, it could be just maybe anecdotal. It might be small, maybe not. It might not make a big difference. But
it's a point. The way to take something that has fentanyl in it,
right,
is different. And so that could change from, as far as, like you say, having the intravenous drug use that leads to it. When we come back, you've heard Dr. Juarez mention this several times, but we want to dig down some in the research that he is doing and his project, which is working out of here at UTMB Health, and also going back to El Paso and going to the border regions and taking a look at the work he is doing. And we'll do that when we come back, right after these words from UTMB Health.
There's nothing more important than quality health care for you and your family. That's why UTMB Health is in the communities where you live, providing easy access to innovative care. At UTMB, we know our patients need personalized care to lead healthy and fulfilling lives, providing everything from primary care and specialty care to urgent care and emergency medicine. UTMB knows healthcare. UTMB knows you. To find a UTMB doctor near you, visit utmbhealth.com.
Welcome back to Healthcare Unmasked. I'm TJ Alds on Pod Now on I-45 now. And before we get to talking, we have Dr. Adrian Juarez. He was leading up the HIV research program within the School of Nursing here, but he's also working on some border initiatives related to that as well. And before we get into that conversation, I want you to take a look at this is from the state. This is the prevalence rate by Texas County per 100,000 population. And now, again, the data was collected was up through 2021, but this report was released just last year. And it may be a little bit hard for you to look at the screen, but if you'll notice that in one of those areas that's kind of the pinkish color, which is one of the higher rates, that's Galveston County. Yeah. Right above that is the darker maroon rate. That's Harris County.
Right.
That shows those areas. So that's our local communities here on that. Not as high in Chambers County, but again, in the third highest range of basically 119 infections per 100,000 for Brazoria County. In our county, in Galveston County, it's 215 per 100,000. And in Harris County, 405 per 100,000, much higher rate that's happening there. Then we go all the way out to West Texas, total new time zone, I should point out
Yeah.
too, right? I like to say that with El Paso. And then that's in that pink range as well,
Right.
Which matches up what we're seeing in Galveston County.
Yeah.
So you have Galveston County on the coast.
Yeah.
You have El Paso on the border of Mexico as well as New Mexico.
Yeah.
There. And I just wondering, but you're seeing similar rates for prevalence of HIV
Right.
there, and the two counties are not next to each other.
Right.
Maybe if they were next to each other, you would see something like that.
Absolutely.
Can you explain to me why we are seeing similar? Because if I were just driving I-10 heading west right now, I go through some yellow, I go through blues much lower, and a lot of light blues, which is the dark blues, which is really low, and one white area that has no reports, low. And granted, the concentrations are there, but this is prevalence, so this is per 100,000. So this is based on those percentages. And then get to El Paso, and wham, it's back up again. Why are we seeing that correlation between these two counties? That population makeup is different.
Absolutely.
Lifestyles different,
right?
In many ways, as far as social, economical, everything else. Why are we seeing that similar type of prevalence rate between the two counties?
So I think I'll start off with, I think one thing that we see similarities, right? Even though they're completely different counties, right? The context is completely different. I think this drives the point that human beings are going to be human beings, no matter where they are, right? But the thing is, though, is that I think this is when we start unpacking a little bit of the numbers, right? So when you look at places like Galveston County, when you look at places like El Paso County or down in the Valley, Hidalgo versus Harris County. So I think a lot of things are going on. So when you see the big metro counties, right, Harris, Dallas, Tarrant, Travis, Bexar County, the thing is, though, is that you have, I think this is where some of what the Fed does, I think has helped. So ever since, whether it be this current administration or even the previous administration, they really changed up the HIV planning, right? The areas of focus and how to look at it. And I really think now it's translated over into what we call, I believe they call them, oh my gosh, I'm trying to blank here, but it's basically the Fed's way of identifying the counties that need, and that usually tends to correspond and correlate over with the population numbers. So, for example, here in Texas, we have a couple of counties that are on the Fed's, focus areas, right? Would be, and those are the counties that I just named, minus El Paso and Hidalgo. But nonetheless, we still have that. But going back to answering that question about why the similarities, when you look at places like Galveston County, when you look at places like El Paso, we have a lot of marginalization, or what we call, as social scientists, we use that terminology, marginalization. But I think in places like Galveston County, it's the socioeconomic status element really plays a part. And when you look at places like El Paso, yes, it's a minority majority county, but nonetheless, that socioeconomic status element is also present there. El Paso or places along the Texas border are some of the poorest in the country, right? So I think that's easy to identify. We've known that, us health researchers have known that, lower socioeconomic status leads to poor outcomes, no matter the condition, right? And I think we see that in Galveston. And not only that, I think one thing that I like to talk about is, UTMB's area, if there's such a thing, but, an area of responsibility, right? We're housed here in Galveston County, and our area of responsibility falls on pretty much basically from here all the way down out to the, to Port Arthur, Beaumont, those areas. And that's where we see a lot of these HIV numbers, that are pretty high. Granted, East Texas has its own, has its unique elements to it that matches other similar areas that, I think I like to use the, like cultural descriptives like the Deep South, right? East Texas really, at least when you look at it from an HIV lens, right? We start seeing that what we see in East Texas is very similar to what's happening next door in Louisiana, out in Mississippi, where we see a lot of, I think. And I should also say, too, this is where, as a nation, this is where the HIV crisis, right, is really playing out just like it did, in the metro areas,
Mm-hmm.
back in the 80s and 90s. Now we're kind of seeing the focus in the deep south, where a lot of these, HIV infections really are skyrocketing. And, East Texas is, when you look at it, East Texas is following that.
In
same
fact,
trend.
yeah, if you take a look at the map, I brought it up again, folks, the HIV prevalence rate by Texas County, you see a lot of yellow over there in East Texas.
Yeah.
And that is 119 cases per 100,000 population. And you see it kind of clustered, but there also in East Texas, and I would take this is probably where we're getting next to Tyler and
Right.
the like too, is that as 215. So it's right in that second tier.
Yeah.
As well, as Dr. Juarez was pointing to.
Yeah.
And when we talk about what you were talking about in the metro area, and we should point out what he was talking about, it was the government likes to call it EMA. It's the eligible metropolitan area.
Thank you. Yeah.
Is what it is. So when you see that, and then it's also the transitional grant area. There was federal funding set up many years ago in the name of Ryan White, who had contracted HIV and then AIDS and then died, and then a foundation started in that. So that's when he's talking about that. So what we're showing you is the chart that's used for that grant funding. Now it's a little bit hard to read on your screen there. I'm gonna go ahead and take it full screen. It's not going to help you a whole lot, folks. But what you see in these metros areas, that blue is, by the way, is gay men sexual contact. Same color schemes that we had before. That grows across the board. And we're going to start in the metro areas. It's Austin is there to the left, then Dallas, then Fort Worth, Tarrant County, as you talked about. Then you get to Houston. Now, this is the city itself plus the region around. So it's going to be a metroplex thing. Dallas and Fort Worth are split up. Normals, they're put together, but it's basically Dallas County, Tarrant County that are separated out there. Then you go to San Antonio along there. And then East Texas, as you pointed out. As a concentrated area. Along the U.S., San Antonio is in there. I should have pointed out before East Texas. Then the U.S.-Mexico border area. Right. And I want to get your definition on that. Is that just El Paso? Is that going all the way, basically El Paso all the way down to Brownsville when we talk about in that demographic?
Yeah, no, I think the state does a really good job about separating out the border counties, because I mean this border is just huge, right? I think in one presentation I put a little blurb in there that it's quicker to get from Washington D.C. to, I believe it was Miami, Florida, than it is if the Rio Grande River was one long road. You'd get to Miami from D.C. a lot quicker than from El Paso all the way down to Brownsville. Yeah. So it just goes to show the size of that border.
But it gives you the perspective of that those grant areas. And the funding is going there because it is still an issue.
Absolutely.
And that is in part what leads to your research. This was a long way for me to get to this here. Yeah. So for folks out there to understand what you're working on, talk about your work.
Sure.
And so that folks can understand what you work on. Yeah. And then the big question for that is why? Why? And then, so let's start with the how and what, but let's get into then the why portion of those, of that.
So again, it goes back to, I think I said this before, when I moved back to Texas, I really started looking at where's the need, right? And then as I started looking at different areas, I started seeing that, the border areas really were underrepresented when it comes to, HIV research and things like that. So that was one element to it. But also this is a I guess what we call it, a hat tip over to a lot of the organizations in the metro areas, right? They're doing really good work. And even though that, MSMs all across the board in the state, and what I mean by across the board is regardless of socioeconomic status, racial identification, self-identification, so on. The thing is, though, is that they have access. They really do a good job in getting a hold of these communities. So I think that's really one area why we've been successful. But on the border, on the other hand, resources are really, really limited on the border. Not only that, we have, and
not just in HIV care,
right? Exactly.
It's all healthcare,
exactly,
all on the border.
And props to the state government for really pushing that, that we have a lot of programs that try to bring in providers specifically to assist in those border areas. So I'm glad to see that, but yet there's a high need. We got, El Paso's maybe not growing as fast as other areas, but definitely when you get down Rio Grande Valley, I mean, it's growing just as fast as other areas across the state.
It's amazing. When I have gone down to the valley here recently, of how there's a new house popping up, a new neighborhood popping up left and right there. And that's probably an area that's going to, because healthcare already, in personal experience on this, is my wife was running a college down in Corpus Christi. And so getting to know South Texas and the Rio Grande Valley nearby, you start seeing the disparity between healthcare.
Right.
And for me, my home base was still up here for the company and all, but this is where I came for my healthcare.
Right.
I obviously was living up here most of the time.
Yeah.
But, but my wife getting an appointment, even with the same insurance plan, and me getting an appointment in the two different communities was stark. So you already have that medical infrastructure working against you.
Yeah.
Now you get into an area like HIV. How much of a challenge is that for where your research is looking at of really folks getting the care that they need? Because there's two factors: access to healthcare, which we have. Yeah. You had said it the other day, and I'll repeat it. We have the greatest healthcare system anywhere.
Right.
Access to it, though,
a
whole different answer.
Absolutely.
You have the greatest thing, but if the door's locked, you can't get in.
Exactly.
Right.
Exactly.
And so I just wonder if how much of that is as you've worked in those border communities in the Rio Grande Valley, that you've been able to see, hey, the lack of access to healthcare, quality healthcare, not just you're in and out. That's what we should say. It's not the lack of access to healthcare. It's like the quality healthcare.
Absolutely.
For whatever factor that's there, contributes to these numbers that you're seeing.
Yeah, I think so. When I speak to colleagues, right, across the nation, I think one thing that is very unique about Texas, right, is its size. So where that plays a part into the access discussion is that we have these rural areas, we have these border areas that are far from these metro areas. I mean, you even in El Paso, and even in places like Lubbock up in the Panhandle, they send a lot of because there's no providers, there's no really really any specialty care kind of opportunities in these areas. So geography is a challenge, and that's a very unique Texas a challenge, right? Just our sheer size. But the thing is, though, is that we already have a shortage of care providers. Then you top that off with we got people, let's say up in far west Texas, you got 3 hours out of El Paso, you got Alpine, you got Marfa, those areas. And the thing is, though, they got to drive. I think there's even there's a lot of media pieces about that talk about how the rural areas are really also experiencing these disparities simply because they live in rural areas. And that's not any fault of their own. That's just because our state is so huge. And, we have these really expansive rural areas as well. So I think that's a very unique Texas challenge. And when I talk about just healthcare in general, but again, since HIV is my focus, I say to get to while there is really good quality care in El Paso, it's very limited, right? I mean, providers can really only take X amount of people, right? Because I mean, they can't.
Yeah, not a doctor can't see 1,000 people with that.
Right. So the thing is, that comparison to we got UTMB is part of Texas Medical Center, but the thing is, though, is that even in places like Galveston County, where we're located at, the access opportunity is there, but still, it's those other elements that keep people away from here, right? And we can get into what those elements are, can be later, but just to speak to the point, geography is an issue, because when you look at our area of responsibility, right down the we gotta we're 90 miles from Louisiana, but the thing is, though, is that 90 miles of limited care access opportunities. So, we have that. And I think just drive the point home that geography really is a uniquely Texas challenge when it comes to healthcare access.
And also too, I think what we're seeing is, and this is definitely a crisis, is the loss of medical centers in rural counties across the state.
Right. Yeah.
And again, it goes to what we've been talking about all along. Yes, this focus has been on HIV here today, but there's so much that's hand in hand with general health care along the way.
Yeah.
It comes down to a simple thing.
Yeah.
If you've gotten an HIV infection,
right,
and along the way, that means somewhere along the way, someone didn't take steps to protect themselves.
Right.
There's doesn't matter where. Somewhere
Absolutely.
along the way, someone didn't take care of themselves.
Right.
And it goes to, I think I shared this with you. I had an old doctor tell me once about that death is preventable.
Yeah.
And I told him, I said, no, it's not. It's inevitable. He says, no, it's preventable.
Yeah.
He says, everyone should die of old age.
Right.
He says, that's the death that's inevitable.
Yeah.
So, but all these other deaths, every one of them is preventable one way or another. And I said, even all this is yes. And he was going a little extreme, but it goes to the point. If you take the point of, yes, it's preventable, there are steps you can take. And I wonder if, that's why I'm interested in your research, particularly, is that if we need that new messaging to come from your research here to say, here's what we found, here's what we could be in 10 years.
Right.
Instead of getting where may be in 10 years, how about we cut that back some? And we take these simple steps.
Right. Yeah.
And some aren't so simple.
Yeah.
Access to healthcare is not a simple fix.
Right. Right.
The access to the medication.
Yeah.
We were going over the prices on this. I mean, $42,000 a year.
Yeah.
For
Absolutely.
some of the PrEP meds that are out there. The pre-exposure, and I'm not going to try to pronounce the last part of PrEP, but that's out there. Those drugs, that's expensive.
Yeah, it is.
And if you are a working mom, 3 kids,
right,
and you just go out every once in a while type of thing, and where your risk may increase, getting access to that medicine might as well be $1 billion. Yeah. 42,000 is equal to $1 billion in those cases.
It is for me.
That's what I'm saying, right? For common everyday people. So, and I think a lot of times, politicians particularly will make a judgment call based on their own lives and not based on the lives of the folks who do. I know you're not going to get in that area, but I wonder too, though, but you are finding some backing for this as well. Talk about some of the folks that have stepped up to the plate with you on this.
So again, like I say, I'll be very specific because, like I said, most of my work is, here in this area, Galveston, Harris County, and out in El Paso, a little bit in the Rio Grande Valley. So it's very specific to those areas. So this may not resonate to a lot of the audience members because they're not in those areas. But the thing is, though, is that one thing that I noticed, right, is that you have, the messaging, right? The messaging piece is one element. And one thing that I saw in my work in focusing on heterosexual HIV transmission was a lot of cisgender females. They were talking about they didn't, it's beyond knowledge limitations, right? The thing, it's just the way that the messaging is made, and there's nothing wrong with that. I'm not making a critique, but the thing is, though, is that when you look at the messaging, because when we get bombarded with a commercial, right? The thing is that that's really the only access to information a lot of people have. So how that translates over into HIV, at least in HIV prevention, the one thing that I saw was that time after time again in my work, I see these heterosexual women when they were asked by me or my team about what is it, why don't you, it's as simple as one, a pill a day, or fairly recently, you can get an injectable and come back in a couple of weeks, right? The thing is, time and time again, a lot of these women were saying oh, I didn't even know PrEP, pre-exposure prophylaxis, was for me. I thought it was only for gay men,
right,
or for the MSM community, or for trans women. That's where the commercials are. Right?
And I'm glad you brought that up, because when you and I were talking yesterday on this, and folks, as you know, this always bring this up is that we always do a pre-interview the day, usually a couple of days before, a day before, so that I can get a feel for what our expert wants to talk about, and also kind of help them get on this. But and I had pointed out to you my own comments on a lot of the commercials that I see, and that's the most prevalent way folks are getting information of PrEP and other drugs that are out there that deal with HIV. Is that something you would not have seen in the 80s or 90s?
Right.
Is that it's gay men in the commercial.
Yeah.
Make it clear that that's what it is. All right. And so folks are seeing that. Now, that wouldn't have happened in the 80s, 90s because there was worry of the stigmatism that would go along with that. Right. That we've tried to address, here. But now that stigmatism, I'm not saying it's not there anymore, but it is figured out as I think Dr. Anthony Fauci, and I know it's a bad name for a lot of folks, but he was on the forefront of this, and Dr. Kaiser also, when he was in Dallas, very much on the forefront of this, talked about it. Says that was a mistake. That what we needed to do was say, don't go think of these people who are out to get you with this, but understand that this is hitting a part of our population, and we need not to step lightly about that. And that's why we saw a different approach to monkeypox. As well, because that was the prevalent population of monkeypox was gay men. Right. And so that's not bashing lifestyle or anything. It's just the facts of where that population's happening. And so as we were talking about that the women you've talked with had said, well, that's not for me, that's for gay men. Physiology is the same, but as far as they're concerned, based on the commercial, it's the drug has been designed in such a way just to work on gay men. Right. And that's not factual, but that's a part that gets, and until you mentioned that to me, it didn't catch on to me at all that could be the message to someone else who doesn't understand that. Right. Like, I know that's not the case. But a pill's a pill. Right. And the physiology in one person, why maybe a little bit to the other, but overall that pill's still going to work. Right. Absolutely. On whoever you are, whatever your lifestyle or your gender choices or whatever it may be. Right. That goes in there. And again, it gets to messaging. The simplest thing to do, I've always said, in preventing disease and making it, is just tell people. Right. And find a way to tell people. Don't always go out to scare them or anything like that, but just tell them the messaging. So if all right, Dr. Juarez, I'm giving you the control of all medicine messaging right now in your area of expertise here in HIV. What are the messages you think folks need to take away or watching this show today? Take away from this to help so your research starts showing different results. Right.
So I would say is, if you want to get that buy-in, show that it's relevant to them. Right. And I think one thing that I love about being a Texan is that we're very dismissive of sensationalism. Right. So I think we see that, like, I don't mean to get off topic, but like, for example, like climate change, right? There's various opinions on that. But the thing is that one thing that in general, whatever you believe about climate change, right? As long as you're not sensationalist about it, right? And I think the same approach should be also with healthcare, right? And I think one thing that luckily, UTMB has, and my dean, right, the School of Nursing, have given me that opportunity to go in and try to fix, while, I think we're in a very privileged position, because in a way that we're there is some success, and there's, but the thing is, because we're actually doing a good job, this is where we can get nitpicky. I always tell my students this, that when they tell me you're being so nitpicky, right? And I say, well, yeah, the thing is, because when something is of quality already, right, we can actually start being nitpicky because of big issues. So I think that's what I mean about when you look at, to get buy-in, right, meet the people where they're at. A lot of people don't like sensationalism. A lot of people, but the thing is that in order to overcome that, well, that's not relevant for me. And I think that's one of the, at least when it comes to medications, right, for example, like PrEP. Right. I think that's where, some of the challenges are. We got to get this buy-in, right? Because time and time again, and this has come out from my own data that I've seen in my own work, right? A lot of, women have said like, well, that's just not really for me. I'm not at risk, Like, I mean, there's even other, one little tidbit saying that, oh, I'm more worried about getting pregnant than I am getting HIV. That kind of speaks to, this kind of marks like, see the messaging right there tells me that we need a little bit of a refinement. Right. And I'm glad that UTMB is giving me the opportunity to work in that space, right? To refine what's already, out there and what's already working. But we just now need to make it fit into the Texas context, wherever we are in the state.
Right. And again, it goes to what you had said, the Texas context. It also goes into the fact is that the information we need to get out there already exists.
Right.
The infrastructure we need to keep people safe already exists.
Right.
We're not having to reinvent the wheel to do this. It is making sure folks are educated.
Exactly.
I agree with you on the sense that it's no different than we're talking about a hurricane.
Right.
If you sit back and say, this is a category 5, it's going to destroy us all. Well, guess what? Category 1 that just came through here was pretty bad too.
Right.
So you just tell folks, here's what you may expect.
Yeah.
Here's what may happen.
Yeah.
Here's what this means.
Yeah.
Know what you need to know. Have your own plan.
Yeah.
And
absolutely.
And that way, when we tell you to evacuate, you trust that we're going to evacuate.
Exactly. Yeah.
COVID, the same thing. I think is we have a lot of retrospective on that.
Right.
That a lot in the medicine have realized is that we need to tell folks, yes, this is a concern.
Yeah.
But at the same time, we need not to get hyperventilating on stuff because the backlash against that.
Right. Yeah.
And in society, not just Texas, anywhere.
Right.
The backlash against that may have done more harm than good.
Absolutely.
And it needs to be a trusted informational source.
Yeah.
And again, I don't like using hurricanes to talk about medicine, but I liken it to Katrina versus Rita.
Right.
Hurricane Rita that came through if you lived in Beaumont, obviously Rita sucked. But that the Katrina effect was here. We saw what happened in New Orleans. We all in Louisiana, Mississippi coast.
Yeah.
But then Rita starts coming this way, and at one point is bigger than Katrina, and all the city of Houston is evacuating, which stuck people down here, and you're stuck on the roads forever.
Yeah.
That brought in a lot of mistrust of government. Of, hey, you guys are supposed to know this stuff.
Yeah.
But it was that Katrina effect on Rita there. And instead of being very diligent about things, that's why plans matter. Yeah. But we can go offline. And as I said, I don't like comparing the two, but they just to give folks, everyday folks to understand medicine, that's a good way of looking at it. Or that goes in there.
And even like, I think if I can share something personal, even the knowledge base, I'm very lucky, right? That I'm a nurse by trade. I have access to a lot of health information, but yet I still got COVID, right? 2 weeks ago, right? The resurgence of COVID is, from a couple of weeks ago, right? But it goes to point that even though somebody is access to good healthcare, has access to knowledge, I let my guard down. Yep. Right. And therefore, so it's the same type of thing, how do we keep, and I think a little bit has to do with, and I'm guilty of it just like anyone else is that, oh, you know what? It's not that big of a deal. Right. But in reality, trust me, it was a big deal.
For the way you
me.
felt.
Yeah, I didn't feel terrible.
I don't care about Paxlovid or anything.
Yeah. Right.
You still feel like crap. Let's just say, right? I mean,
exactly.
And that's why I tell folks, you just really don't want to feel that way.
Yeah.
Yeah. Maybe it's more manageable now, obviously, than before. You still don't want it. I mean, it's the same that we started the show with on HIV.
Yeah.
Yes. It's manageable now than before.
Yeah.
You still don't want it.
Yeah.
Let's be honest here. You don't want it.
Exactly.
Right?
Exactly.
And there's ways that you can prevent that.
Yeah. And it just goes to emphasize the point you made about having a plan.
Yeah.
Right. So when I tested positive, I think it was more than a month ago. I can't even remember now anymore. But the thing is, though, is that I had a plan in place. Right. I mean, yes, I'm lucky that I was able to access healthcare and things like that. But the thing is that I had a plan. I knew what to do. Right. I knew my care and not only that, my care providers. And actually, I was talking to my care provider when this happened. Like, we're very fortunate that we learned, we learned how to manage COVID off of the first batch. Right. Off of all the deaths that happened, when COVID started coming around. A couple of years back. But the thing is, though, is that I got thinking like, just across the board, we need to reemphasize that messaging and remind people, and make it relevant again, right? Because here I was, this like, pretty healthy middle-aged guy, just kind of doing his work in sunny El Paso, but yet, I let my guard down.
Yeah.
And sure enough, that's what happens. And I think the same can be said about HIV prevention, right? When we have HIV, when we have an HIV little hotspot, right? The thing is that we need to, be a little bit more proactive as care providers and researchers and identify those areas, because then we can reiterate that message and remind people that, hey, you know what? Let's not be sensationalist about it, but let's at least acknowledge that, that there still is, an HIV risk, right?
Yeah.
And I think that's the most important part.
And that's great. And that's also something to, as kind of an offshoot of what you talked about.
Yeah.
And I have that little notebook here reminding me of this. That's why I'm really proud of what we're seeing at UTMB Health, school and public and population health.
Absolutely.
That's really getting some legs under it now.
Yeah, it is. It is.
And thank you, Dr. Reiser, brother. We should point it out that's a big thing for him,
Yeah.
between the partnership that UTMB Health, public health has, and now with Galveston County Health District.
Right.
That we're seeing some really, because they're going to take data that you've got.
Yeah.
And they're going to take that and say, all right, what do we got around here we need to tackle?
Yeah.
And get into those communities, do education, provide medicines, provide whatever they need to do for prevention.
Yeah.
And they're able to swarm, hit an area. And if you do that, that helps the surrounding areas too. And that's great. Dr. Adrian Juarez, thanks for coming on.
No, thank you for having me.
Glad to have you on. And I need to come up with a prize for when we get someone on as a first time guest, something for you for that, because he's our first time guest. Our first time, he was very nervous about coming on the air with us.
Yeah, I still am.
To see the email, you did great. I mean, you did great. And you can follow him. We've put up some links for you to follow his work. For you to follow along there, folks, and make sure you click on those and share this with your friends as well. Reminder to you folks, only because I know it's coming up. It seems like, hey, it's still summer. No, it's actually, we're about to hit fall here pretty soon. And we're already planning for Broad Dazzle coming up in October. Let me pull it up while I'm on my calendar here. I think we're October 6th, but I'm going to reconfirm myself. No, it is October 3rd that we're going to have Broad Dazzle 2024 coming up. So we're already planning that right now. And I-45 now is a big partner with UTMB Health on Broad Dazzle, which raises funds. So the mobile mammography program here at UTMB Health as well. And we want to get you on again and talk about all your border state stuff is really interesting. I think that it does affect this area. What happens in the Valley, what happens in Brownsville, what happens in El Paso does affect here because of the commerce that goes through, right? Both illegal and illegal commerce, we should point out, that goes there here. And so in following your research there, I think would be very interesting.
I'd be happy to come
glad
back,
to have you back there as well. And join us again the third week in September. I don't know what our subject matter is yet. We haven't decided this one. We know October is always going to be one of those things that we may do it in September, though, the preview of our Broad Dazzle and breast cancer awareness programs that we try to do as well. But stick by for that. And as a reminder to you, too, folks, we're back at school. So get those kids, or as my wife likes to refer to him. She, she's an educator at heart, even though she's a vice president now of a university. She goes, those little petri dishes, get them to the doctor, and get it there. But watch out for the colds, and as you heard, Dr. Juarez said, watch out for the COVID as well. I'm TJ Alds. You've been watching Healthcare Unmasked, presented by UTMB Health.
UTMB knows when you're expecting, you may not know exactly what to expect. From that first embrace to all the milestones that follow, we know how important each stage of life is. That's why UTMB Health's obstetrics and gynecology physicians specialize in innovative women's health care through all phases of life. UTMB knows women's health. UTMB knows you. To find an OBGYN specialist near you, visit utmbhealth.com/women.